Hello, and welcome to my presentation, The Effects of Psychoeducation in Family Therapy Sessions for Adolescents Diagnosed with Major Depressive Disorder Mild. According to the National Institute of Mental Health, 13.3% of the United States adolescents aged 12 to 17 have had, quote, at least one major depressive episode, end quote. With this statistic in mind, and after reviewing the needs of the different families that are treated at Chicago Children's Center for Behavioral Health, there is a greater need of research surrounding major depressive disorder mild and the effects of psychoeducation, starting with psychoeducation that is provided to the family and patient before attending a family session. Timbery et al. In 2016 suggests, quote, that family psychoeducation as a supplement to traditional treatment can effectively reduce the risk of relapse in patients with major depression, as well as being beneficial for the relatives involved. End quote. I plan to implement a summary sheet provided by therapistaid.com, a cheat sheet, if you will, which is attached at the end of this proposal, that details facts regarding MDD in order to better educate families and the patient in hopes to increase the patient's recovery rate and lowering the chance of repeat hospitalizations. Bernito et al. In 2017 suggests, quote, the efficacy of interventions may be enhanced with a broader therapeutic focus on family factors such as communication, conflict, support, and cohesion, end quote. With this idea that families and broader systems need to be involved in order to better understand the diagnosis and how to better support loved ones, my research will take place on an inpatient unit at Chicago Children's Center for Behavioral Health. Quote, approximately 60% of the patients who have had a major depressive disorder will have a reoccurrence, end quote, according to Eggard et al. In 2017. By targeting patients who are hospitalized for the first time during their first family session, this research can show how the efficacy of psychoeducation for major depressive disorder in adolescents and in the future bring light to more research that needs to be done in order to decrease the reoccurrence rate previously reported. By focusing on adolescents in the inpatient setting, it will be easier to include family members during the psychoeducation portion for the first family session due to the guardianship and general need for involvement of adolescent families. This experiment will take place at Chicago Children's Center for Behavioral Health on their adolescent inpatient units. These units hold up to 15 adolescents each, separated by gender, and the average length of stay is 5 to 7 days. Each week, I will meet with one adolescent patient that has been formally diagnosed with major depressive disorder without psychotic features and complete the first family session for the patient and their family. The psychoeducation worksheet will be provided during the family session with the patient and parent present. A family session is a meeting with the patient, parent, and therapist that lasts around a half hour. During the family session, we discuss the diagnosis, potential length of stay, and treatment plan for the patient. I would then present the psychoeducation sheet provided by therapistaid.com during the treatment plan portion of the family session. According to Brady et al. In 2017, quote, FPE interventions are based on the premise that if you increase family members' understanding of the illness, this will reduce distress and improve their ability to cope, which will result in improved outcomes for the patient, end quote. My intervention strategy starts with an initial meeting with the patient individually where the patient and I will review the formal diagnosis. I will then have the patient journal a short summary of their outlook and at the bottom provide a ranking regarding the major depressive disorder diagnosis using the Likert scale shown here. Next, before the family session, I will meet with the patient 5 to 10 minutes prior and review the MDD education sheet shown here, provided by therapistaid.com. Together, we will review the symptoms and the two main identified treatment options provided. After I have reviewed the psychoeducation cheat sheet, we will conduct the family session in which together the patient and I will also review the summary sheet with the parents. After the family session takes place and the psychoeducation has been shared, I am then going to ask the patient to journal a second time. This time, it will be another short summary of the patient's outlook with a new ranking at the bottom using the same Likert scale as before. I hypothesize that after sharing the psychoeducation sheet with both the patient and then again with the patient and the family during a family session, the patient will rank their outlook higher than they did the first time, proving that supplying Both family support and psychoeducation together is more effective for treatment long term. Berger et al. In 2014 suggests, quote, uncertainties about how to deal adequately with patients and their illness-related behavior, as well as negative emotions like guilt, anger, or worries about the patient's future are common, end quote. Focusing on inpatient adolescents can lead to a very small and non-diverse sample size. I am limited to specific adolescents that I have no control over selecting. It is more difficult to monitor my sample size. I am also bound to the census of the hospital, and that can vary depending on the week, leading to an inconsistent sample pool. Oftentimes, the patients that are hospitalized have come from DCFS and are categorized as youth in care. This can lead to a disadvantage for my study due to the lack of family support provided. Thank you for attending the presentation today.